Everyone, this is Dr. Sushma and welcome back to my channel. Today we are talking about something really important, Ludwig's angina. It's a rare but serious medical condition and understanding it can help you to respond quickly in critical situation. So let's dive in without any delay. We'll be covering this topic under the following headings: definition, etiopathogenesis, diagnosis, clinical features of Ludwig's angina, differential diagnosis, complications, followed by management. Ludwig's angina can be described as a rapid progressing cellulitis infection involving the submandibular, sublingual, and submental spaces in the floor of the mouth. This condition is typically bilateral. It can spread to the surrounding neck tissues, potentially causing the airway obstruction. This term was given by a German physician, Wilhelm Friedrich von Ludwig, and angina comes from the Latin word which means to choke. If we talk about the etiology, that what causes Ludwig's angina, the odontogenic infections, especially those from the lower second or the third molars, have been the main cause of Ludwig's angina. Apart from this, the cellulitis, peritonsillar abscesses, open mandibular fractures, trauma to the floor of the mouth, and even the tongue piercing have been reported to cause the Ludwig's angina. In most of the cases, Ludwig's angina develops in previously healthy patients, but there are some predisposing factors which may lead to or which may increase the chance of Ludwig's angina, which may be a diabetic patient, if the patient is alcoholic, malnutrition patient, or the patient is having immunosuppression, as in the case of the AIDS, or the patient who has received an organ transplant and is on the immunosuppressants. To understand the pathophysiology of Ludwig's angina, it is important to know about the anatomy of related structures in the submandibular space. In the healthy mouth, the area under the tongue and surrounding the lower jaw is called submandibular space, and this space is very important for the normal oral functions. Submandibular space has three main areas: the sublingual space, which is present beneath the tongue, the submandibular space is under the chin, and the submandibular space is below the jaw. The submandibular space is subdivided into sublingual space, which is present above the mylohyoid muscle, and below the mylohyoid muscle, the space which is present is submaxillary space. These two divisions, they communicate with each other. They are in contact with each other over the posterior border of mylohyoid muscle. In most of the cases, Ludwig's angina is polymicrobial infection. That means it includes aerobic as well as anaerobic bacteria. The most common bacteria which is involved is a Streptococcus species, especially the Streptococcus viridans, which is alpha hemolytic streptococci. Apart from this, Ludwig's angina can be caused by Staphylococcus aureus, bacteroids, and the fusobacteria. Diagnosis of Ludwig's angina is primarily, it relies on the clinical assessment only. Laboratory testing has very little immediate value in diagnosis of Ludwig's angina. But the blood cultures can be obtained to determine if the infection has hematogenous spread. And if we want to do the culture from the affected area through swab or the needle aspiration, it's not having much diagnostic value. Now we will discuss about the clinical features of Ludwig's angina. Now think Ludwig's angina like a rapidly growing sinkhole beneath the ground. Just as the sinkhole swallows up the surrounding earth, causing sudden and severe damage, Ludwig's angina spread quickly from an infection under the tongue into the surrounding tissues, creating a medical emergency. Like the sinkhole causes everything around it to collapse, this infection causes swelling and pressure that can close off the airway, potentially leading to collapse of body's breathing system if not treated immediately. The patient with the Ludwig's angina presents with a browny edema of bilateral submandibular, sublingual, and submental spaces. It is woody hard and it spreads very rapidly. It is non-fluctuant and tender also. The tongue is elevated, which may lead to the difficulty in mastication, speech, swallowing, and the drooling of the saliva is also found. Airway obstruction can occur due to the edema of glottis, and there is also hoarseness or stridor or choking sounds may also be found. Despite of the infection is so severe, there is always a paucity of pus in Ludwig's angina, and it is toxic in the nature. Fever, dehydration, and septicemia may occur in the patient. Patient may also present with massive swelling or induration, that is hardening of the neck, which gives the neck a thick, firm, or the rigid appearance resembling a bull's neck, and so that's why it is also known as the bull neck appearance. Here I have provided you the list of the other diseases or the oral infections which may be confused with the Ludwig's angina. The most common, rather the serious complication of the course of infection is respiratory failure. Apart from this, the patient may also have medianitis due to the inflammation which spreads into the central compartment of thoracic cavity. The infection, it also becomes systemic and known as a sepsis, and it's a very life-threatening condition, and it can result in death of the patient also due to all these obstructions, or all these complications we have talked earlier. Discussing about the management part, the foremost management of the Ludwig's angina is to secure the airway of the patient. Airway management is crucial. 6 primary points in the management of Ludwig's angina is, first of all, the early diagnosis is a better prognosis. Then the airway management, which is very essential for overall prognosis of Ludwig's angina. The patient, if hypoxic, should be given the supplemental oxygen. Cricothyrotomy or tracheostomy is sometimes performed as an emergency maneuver in the advanced stages of the infection. Prolonged intravenous antibiotic therapy for 5 to 7 days is given. The penicillin plus metronidazole can be given, or the clindamycin, imipenem, or the cephalosporins can be given in sometimes. Hydration of the patient is very important. Early incision and the drainage and the extraction of the affected tooth. Surgical intervention must be attempted to drain all the abscessed spaces. Bilateral submandibular incisions, or if required a midline submental incision is also given. The submandibular incision is given 1 centimeter below the inferior border of the mandible, and it is sufficient to drain the involved spaces. Intraorally incisions may be also given. They are given parallel to the ducts or submandibular gland. After the incision, the exploration and attempt is to made to communicate with the spaces of the infection by breaking the septa, dividing them, and drainage of the content are achieved with these incisions we have talked earlier. Rubber drains are placed in order to keep the drainage sites open for at least 3 days and until the clinical symptoms of the infection have resolved. Pain treatment should always be backed up with the supportive care, which includes the intravenous fluids for the hydration and the pain management of the patient. With prompt and appropriate treatment, most of the patients suffering from Ludwig's angina recover without significant long-term complication. But here the time is the key. Delayed treatment can result in significant morbidity or even the mortality. Recognize the condition early and do not waste your time on imaging the patient. Communicate with the anesthetic early only to improve the overall prognosis of Ludwig's angina patient. So this was all about Ludwig's angina. I hope this video helped you to understand Ludwig's angina in a better way. Remember, early treatment can save lives. And if you found this video helpful, give it a thumbs up, share it with your friends, and don't forget to subscribe for more videos like this. See you next time. Bye bye. Take care.